called fissures. So this is called an oblique fissure because it runs at an oblique angle. So it divides it into the inferior and superior lobes of the left lung. The right lung will have an oblique fissure and a horizontal fissure. And this allows it to be superior, middle and inferior lobes of the lung. And if we were to look at the lungs, the differences that we'll find is that the right lung is much more wide and shorter. It is wide and shorter because under the lung, if we were to remember, under the lungs we have the diaphragm, which is another muscle that's used for breathing. And under the diaphragm, under the right lung, inferior to the right lung, we have the liver there. So really, the liver more or less pushes the right lung superiorly. So it lies much higher than the left lung. And even if we were to look at the divisions, if we were to look at the carina, we'll find that the one for the right is much lower than the left, albeit that the left lies at a much more horizontal angle because of the heart. So the left lung is much more elongated, and it looks much thinner than the right lung. And importantly, the left lung also has a cardiac notch, which means that it has a surface that is an imprint of the heart. So if we were to flip it over and look at it, or if we were to look at it from a posterior angle, we'll find that there is a cardiac notch on the left lung itself, which means that that's an imprint of where the heart is. So the heart is sort of there, coming into like the apex of the heart. So then the left lung, also the inferior lobe of the lung, also then forms something called a lingula, which covers a bit of the heart as well. So the heart will be there, more to the left, and the sternum will just lie there. So now, in going back to the lungs, if we just look at the lungs in terms of their covering, they are covered by a pleura. Pleura is just mesothelial cells, really. So pleura. And the outer surface is the parietal pleura. And the inner pleura is the visceral pleura. And the visceral pleura is actually tethered onto the lung parenchyma. Even if you were to try and dissect it, you could not dissect the visceral pleura from the lung because it's actually attached, firmly tethered to lung parenchyma. So it is tethered to the lung. And the differences in pleura really are that the parietal pleura has all the nociceptors. It can sense pain. So this is important really in terms of things like when someone has pleuritis, or in terms of an injury, that pain is mostly sensed by nerves which innervate the parietal pleura, and the visceral pleura doesn't have any nerves. So if we were to look at the pleura really just from a simplified point of view, this would be our visceral pleura, and this would be our parietal pleura. So in between the visceral and parietal pleura, there is a pleural space there. It's it's not a space, let's just say it's called a potential space, a potential cavity, shall we say. And that potential cavity has inside it serous fluid that is secreted by the parietal pleura. So we'll have that. And the importance of that, so if we're to go back to, say, to the heart, we remember we talked about the pericardial fluid. So this is exactly the same in terms of it's secreted by the parietal pleura and absorbed by the visceral pleura. And all it does is it reduces the friction when we breathe, as lungs are moving inside the rib cage. And if you were to remember, the lung is actually tethered to that visceral pleura and the rib cage is out there. So that potential space is tiny. We don't really see it. It's filled with the fluid, and that fluid really allows for those lungs to move in and out of that, well, to move against the rib cage. It does not move in and out of the rib cage. It moves against the rib cage without any friction. However, say when someone has pleuritis, say if it's something that's coming from the lung and causes I don't know, say an inflammatory process, which is what pleuritis is really. So that inflammatory process causes both the parietal and visceral pleurals to fuse together, and when they fuse together, the parietal pleura then senses that pain, so that sensory senses that pain, you know, so that the pain that is felt when, say, there is trauma perhaps to the ribs cutting through the pleura is all sensed by the parietal pleura. The other important thing to talk about, all the pleura is drained by all the pleura and the lungs are drained by lymph nodes which come from, well, they're all named based on where they are in the body, but the more important thing is that they all drain there into the hilar of the lung. And the hilar of the lung is what is also called the root of the lung. So this is the hilar. It's also called the root, houses the root of the lung. And by root we mean it is the area where the bronchi enter the lung. It's also the area where the vessels enter and leave the lung. If we're to remember from cardiology lectures, the vessels that we're talking about are the pulmonary arteries leaving the lungs with oxygenated blood, and the pulmonary veins arriving at the lungs bringing in carbon dioxide rich blood. So these are the vessels that are coming from the heart coming into the lungs in order to facilitate gaseous exchange of the two gases that they are carrying. So now, and these, the hilar there is much more important because it has the hilar. So it is the root, as I've shown, where the vessels and the bronchi enter and the airways enter the lungs. So at the hilar, we have the most important hilar lymph nodes. And hilar lymph nodes are important in the sense that, say if someone has mesothelioma from the pleura, like any pleural cancer or any lung cancer, it all drains into the hilar lymph nodes. So we can actually call them the sentinel lymph nodes. Sentinel lymph nodes, as in, you know, they are the indicators. So really, that's the most important thing about the hilar lymph nodes, that they are the main drainage pathway for anything that's coming from the lung and from the pleura and from the, you know, the bronchioles, the bronchi, like any cancer, like a bronchotracheal cancer, they all drain into the hilar lymph nodes, and then they are obviously then taken out to go back into the system. And as they drain out from the hilar, on the left side, they will then ascend superiorly and they will enter the system via the thoracic duct. And if we're to remember the thoracic duct, I should have done this when I was doing the vessels. The thoracic duct enters the circulation at the venous angle. And so if we're to remember the thoracic duct, the important bit about the thoracic duct is obviously that it carries what is it called? Lipoproteins, and you know, things which cause cholesterol. It's used cholesterol. It's used for the absorption of lipoproteins from the GI tract. So, and then it carries all those from the GI tract into the venous circulation, and it also carries all that lymph fluid from the hilar and from the thoracic cavity into the thoracic duct back into the circulation. So and it enters the circulation at the venous angle. The venous angle really is just where the brachiocephalic, I can't believe I said brachiocephalic. Well, the beginning of the brachiocephalic really is just where the subclavian vein and the jugular vein meet to form the brachiocephalic vein before before the left and right brachiocephalic then form the SVC and then enter the right atrium. So this is the venous angle where the thoracic duct actually enters into the circulation. And then on the right hilar finally drains into we just call it the lymphatic duct. And that lymphatic duct as well, it's at the right venous angle. So in this introductory to anatomy of the respiratory system, I have covered the structures from the nose up to the alveolar. I've also covered the lungs themselves. I've also briefly looked at the circulation as well, including how all the structures receive their blood. I have not covered how lungs and intercostal muscles receive their blood, because I'll do that when I do the next anatomy section. I've also covered a little bit on the diaphragm and the liver and how they influence and the heart, how they influence the structure and position of the lungs. And I've actually covered a lot on how the lymph drainage of the lungs, and obviously the lymph drainage is much more important for things like lung cancer and then infections of the respiratory system, particularly the lower respiratory system. So in the next section, I'll quickly talk about the blood supply to the lungs themselves. It's obviously via thoracic arteries and veins, and the lung supply into the interthoracic muscles and the diaphragm, and also then put that together with breathing to show how the intercostal muscles lift the ribs, and how the contraction and relaxation of the diaphragm influences how we breathe. And then after that, I'll move into pathology, or gases exchange, and then pathology.